Well, since the turmoil has passed about Ebola, but the concern is still there, and now the pandemic has become an endemic. So we still need to be prepared, keep constantly training and keep on going with what we have developed. So I want to talk about how we developed this laboratory. First of all, I just want to thank the whole team that participated in developing this lab, starting with our, at that time, laboratory president services, Carrie Warner, who was very instrumental on helping to acquire the facility and all the instrumentation. Also, I want to special thanks to our laboratory manager, Chris Sen, which also was very instrumental in getting all the resources and the key components of this laboratory. Special thanks to Sherry Humphries, who also worked hard on developing the work aids and for the PPE and for laboratory work. And all of the point of care coordinators have also helped with the validation of the testing. So a brief summary of what happened. As you were very informed, in the summer of 2014, breaking news were announcing that 2 adult U.S. citizens contracted Ebola in Africa amidst a large Ebola outbreak over there. Knowing that we have a diverse population here in Minnesota that have links to Africa and those affected areas, so the University of Minnesota Health System organized different meetings to identify the potential risks that we could potentially be exposed to. At the beginnings, there were fragmented efforts by sites or individual locations. Most of the Fairview site facilities, they felt the need that they need to be prepared. Like probably all of you too in your respective hospitals, I'm sure you were talking about it or meeting about getting ready for this. Once the consensus was reached about that a designated hospital it was needed, not different location but one central one, the laboratory planning began. By September 2014, the preparedness site-based efforts increased and the laboratory began ordering and acquiring key equipment. Almost at the same time, a Texas hospital became under fire. A Liberian man without was released without being tested for Ebola. He later became ill and unfortunately he died of the disease. Later, a nurse who treated the man at the same time at the same hospital also came down with Ebola. And this was tracked down to a breach in protocol, the breach in a protective equipment protocol. The situation escalated to the max, and our preparations also were escalating. By October 2014, with the situation escalating nationwide, the Hospital Incident Command Center was activated. So Carrie Warner, as I mentioned before, the laboratory assistant president at that time, was designated as the incident commander. So the incident command system was composed of the hospital incident command center system, and then acted in office from October 2014 to November 2014, and it stayed active for that time. By November 2014, January 31st, 2015, it became virtual, so in an on-call base. The infrastructure support, it was composed of interpersonal professionals from all levels of professionals, including physicians, nurses, laboratory professionals, infection prevention, and environmental services staff. All part of the organizations contribute with resources, time, money, and talent. There were meetings and meetings in a single location. The gap analysis turned out that we need to develop our own protocol of care. So what was needed? We needed to develop our checklist. We needed to go to check the Centers for Disease Control. the Health and Human Services, and the Assistant Secretary of Preparedness and Response, looking for information. How are we going to be ready for this? With this valuable information gathered, we established a framework, and these were based on 3 components: detect, protect, and respond. So a standard work was created by teams for patient screening in all entry points, emergency departments, operating rooms, OB, clinics. Persons of interest will be transferred to a designated hospital containment unit. We base our decisions on the following principles: protect our patients, family, staff, and communities. Provide a confident response at any point of entry to our hospitals. Develop a single containment unit for adults, pediatric, and OB patients for the federal system and University of Minnesota Health. Develop a specialized expert team to provide care, training, and ongoing testing, validation of plans. Make evidence-based decisions. All these efforts were important to decrease the variability across entities to have a standardized process. Detection. A standard work process were created, checklists for screening to search for the recent identification, triage patient based on the symptoms, the process of flows, algorithms, all the signals necessary to keep providers and community informed. So this is a diagram of how the incident command was formed. So we have several components: a PIO, Police Information Officer, Safety Officer, Liaison Officer, and all of the other logistic and financial members. We talk about the infrastructure of how the team was formed, the gap analysis. These are all our principles, and we talk about that too. And what was important for us to develop a strong partnership with the Minnesota Department of Health, because they had information that there is given to them by the CDC. If a personal interest is submitted to the hospital, communication via blast page, text pager, email, or phone calls will be sent to staff team members. Laboratory process for collection and transfer of confirmatory samples were sent to the MDH. So now we had to identify the location. So we found that an area in the ICU was perfectly fitted for this endeavor. So this is how one of the areas of the ICU was completely developed into a containment unit. So there's I don't have the mouse in here. Well, anyway, on the right, you can see that there's the access with the locked doors. There's just accessible by authorized personnel, and there's 2 sets of those doors. And all the area in green is mean that there's a clean area, so anyone can walk in there with no PPE. Then we have the yellow area, which is the warm zone. It requires Tier 1 PPE. And the red zone, which is the patient room, which requires Tier 2 protection equipment. So anyone can walk from the green zone to the yellow, but you cannot walk from the green, from the red to the green. So you have to follow a strict protocol. Now, selecting the appropriate PPE products. So as you can tell in the picture, we had hoods and poppers, aprons, gloves. All of that was based on the Emory and the CDC guidelines. And this is where based on that, we developed our donning and doffing processes. The next step was training all healthcare providers. So we had around 22,000 employees. So our online module was created by our SNO, System Nursing Orientation, and it was 15 to 20 minutes. It just goes through the Ebola, the virus, and how it gets transmitted, and how can get protected. approximately 1 hour for ambulatory and other access point of training, 3 hours of PPE training in the emergency department OV lab containment unit, 4 hours of Ebola training specifically in the containment unit lab, 4 hours of team building. And this was important because our members were based on volunteers and from different areas, so we needed to know each other. We're going to be there for hours in a emergency situation, so we needed to know how to cope during that time. So the team building meeting was very crucial in this time. Simulation drills, 2 hours twice per week when the crisis started, and now is just done quarterly just to keep up with our training. Nursing training probably take the same time. So the readiness was tested at various points across the system. Plan of care development includes person of interest, confirmed or not confirmed, adult, obstetric, pediatric, and neonatal. We needed to assure that we had the right personnel at that time. So we were fortunate to have professionals from the different areas that called for when we called for volunteers. So some ethical considerations include plan of care according to patient population, operation decision, testing menu according to the patient's condition. Staffing, as I mentioned before, is volunteer-based and self-assigning in the containment unit lab. So we have a shared folder and that all the members of the unit can sign for their hours to be on call. And it's mandatory on the access points on OB, ED, and lab. The Ebola clinical co-response team is formed by 1 MD, 2 RNs in the room, 1 in the anteroom, 2 lab techs. It's a mix of CLS and LCTs, 1 lab monitor, 1 environmental service staff. Other specialists will be involved depending on patient's conditions needed. So we will probably require cardiology, will probably require pharmacists. So there will be, depending on patient's condition. HR and the employee health services will provide the payment, the housing, monitoring of the Ebola team members. So if someone gets contaminated, then they will be placed in a location and then will be followed up by the respective professional. Ongoing readiness requires continuing training, education, frequent simulation drills, partnership with NDH, EMS, MEH, monthly conference, and we're still doing those. So we just keeping up to date with what we're doing, what is next, and they're scheduled also as needed. The guiding principles of the containment lab. Patient and staff safety is the first priority. That's why we established all these guidelines to make sure everyone is protected at all times. Testing is provided within the containment lab. The staff is fully competent to fulfill work expectations. Staff participation in the containment lab is voluntary. Plan of care decisions drop the test menu. And then we utilize the Emory's lab design as a model. Supplemented test offering based on physician care team needs and patient populations. The unit is capable of serve any patient population, adult, peds, neonates, and obstetrics. Added additional testing in order to assess condition diagnosis other than Ebola. So this is basically our test menu. We actually just use what we have in a point of care settings or in the laboratory. So we have ISTAT. We also acquired the Piccolo for liver enzymes, and the Sysmec, a small version of the Sysmec for point of care, Cascade for INR PTT, and all the other manual testing. Something new that we need to learn was also to test for malaria. So we needed to be trained in rapid malaria. And if the malaria is also, if it's not conclusive, inactivated slide will be sent to IDDL. Blood cultures are also incubated in the containment unit. Inactivated slide will read in 2 to 5 days. We provided rapid flu, RSV, rapid strep, rapid malaria, Agnisure, AVO. We were also considered to do AVO testing in the lab, using just the traditional manual slide. Red blood cell components were available if needed in the main lab, and also other blood components. All testing is performed within a containment laboratory with the two exceptions. So rapid malaria will be performed as the first step. If additional testing is needed, a slide is made, vitally inactivated, and sent following careful handoff protocols to the infectious disease laboratory. Blood cultures are incubated on site, and gram stains are made at 2 and 5 days in the containment unit. After being vitally inactivated, are sent to the infectious disease laboratory, following a strict protocol. Training. So I mentioned that there was a module created for everyone, and that included 25.25 hours. PPE class, scheduled LMS, also 3 hours. Lab training, simulations for lab training, simulation for lab training that include test menu, order reporting, and many other gaps in training, and other testing regarding Ebola. Quarterly training for each member. It takes 2.5 hours of CEs. Define roles for the laboratory staff performing testing. So we have the laboratory in an emergency situation will be staffed with 2 laboratory techs. So we have the one that is called the primary, is the one that is assigned to perform the testing. The second one is called the body, and who is the one observes to ensure no breaks in practice and provide supplies to the primary as needed. So the body will read out loud the workflow to the primary, and the primary will follow strictly all what the body says. It's like the game of Simon Says. There's a 3 component. There is a monitor. The monitor can be anyone in the main laboratory that is called to deliver a supply, blood components, or to pick up the slides to be sent to IDDL or the malaria slide, gram stain or malaria slide. So that person does not require PPE because it's walking through the green or clean area. Also, a QK lab staff will support that. Okay. Develop a detailed workflow for the lab. Process for donning, shared with nursing and doffing, included the last lab staff to exit the containment lab safety. Clean handoff process to transfer a collected specimen from the patient room, the hot zone, to the containment laboratory. There were 8 workflows. Process to transfer specimen to NDH or IDDL cannot be completed within the containment lab. Handoff of supplies from the acute care to the containment laboratory. And 2 workflows for handoff of paper and paper disinfection workflow. So a lot of paper, a lot of flows to follow, and we had to do it word by word. Ensuring staff safety through meticulous workflows. Doffing is the ultimate game of Simon Says. Coach reads a step number and entire process out loud, and then watches a step being performed. Person doffing repeats step number out loud. Person doffing does not proceed until the coach reads the next step. Person not performing an action is always observing to ensure no breaks in protocol. And this is why probably the monitor that is in the clean zone will probably work also as a body being outside there, observing that there's no breaks in protocol. Think about your move before performing the step. Do not touch any surface that someone is in a hotter zone has touched without disinfecting. For example, don't touch the toad in the green zone unless you are also in the green zone. When passing another employee, pass facing each other, following the model on the OR, instead of passing with your back to your coworker. When doffing, the haircare worker progresses from hot red area to warm yellow area, then exiting to cold green clean hall. Tape lines on floor are used primarily for doffing. So this is the diagram of the containment unit. This is a picture of the containment unit. You can see the hallway is the green zone. And you can see here, there's 2 tapes in there that limit the clean area, the green, and the yellow warm, and that is the anteroom. The laboratory is also considered a warm zone. Even though we were working with specimens from the patient, the potentially contagious patient, but we worked to a PPR. But the laboratory is considered warm zone. So these are the lockers where the staff will change to their scrubs. There's also a shower in there that they can use after. This is our patient visitors and family lunch. This is an area where they proceed to do the donning. And you can see there's two of them that are working in the process of getting ready. One of them is making sure that the slip of the gun is under the gloves. And the other one, the third one, is observing that there's no, also that everything is being followed by the protocol. So this is, behind the door is the patient's room, and you can see below on the floor there's a red tape that limits the hot area. And then next to it is the yellow tape, which is, tells you where you are in the warm zone, and that was actually open. There wasn't a door in there, but we thought that we needed an anteroom, so there's no breach on protocol. So we even though we walk outside of the red zone, we're still safe because we will be in that area, which is also warm, instead of being directly working in the green zone. So this is a picture of the laboratory. As you can see, there's two safety hoods. One safety hood was designated for the main laboratory testing. So inside, you can see there's a cascade for INR-PTT, the piccolo for chemistry, liver enzymes primarily, and also the iostat for electrolytes and blood gases. Next, in between the two safety hoods, there's a Sysmec pouch 100, and next to it is the Sophia for rapid flu and RSV testing. The next safety hood, it was designated for the microbiology testing. So there will be performed the rapid malaria, will be make the thin slides of malaria to be sent to the IDDL, and also the gram stains for the culture confirmation. And our card was designated for the supplies and for the manual testing, kit testing. The room, it was designated as air negative flow. So initially, we were assigned to a small room. I think it was the nutrition room. And luckily, Carrie Warner, our laboratory president, was in the incident command center. So she was very concerned about the laboratory people to be exposed to the virus because of working in limited space, and she advocated to get this bigger room and also all the equipment. And the room was built with air negative flow. So this is a picture of the hallway. As you can see there's two monitors that are not with PPE, and there we see a Cherie that is already done, and she's ready to go inside the patient's room. And this was actually our real case. So inside the laboratory, in that time, it was, I think, December 13, that we were called. We got the blast page, and actually, coincidentally, Cherie and I were working that weekend. And it was almost at the end of our shift, and we got the page, and we say, okay, well, we're in. So we walk in, I'm inside the laboratory getting ready, getting the controls, getting all the equipment necessary. And Cherie was called to help with the draws. And Chris was helping with the supplies and making sure that we need everything. So the following spreadsheet that I'm going to show you, there's probably not really related to Ebola, but it was useful to have it. So since the inspection protocol tells us that nothing came out of that room, without proper management. So there were this spreadsheet that we developed for a different scenario, and this was probably were part of the process improvement or CMP inspection, and we thought that were suitable to use it in the containment unit since we don't have to save paper. So the spreadsheet that I'm going to show you is just an Excel spreadsheet that has been built with pop-up messages. In the way that every time the user hovers the mouse over the cells, a pop-up message will show that, and it tells them what to do. If the result is out of range, then it will say, this is out of range, you have to rerun it or call point of care. And also you can send, since this is a share folder, any areas in the hospital within the system, an authorized user can access it and enter the results. So in that way, we can immediately take action. Monitor this on a daily basis, and we detect any problems. If it's nothing that urgent, we can just put an arrow with a message to take action. If it's something very urgent, we will call and tell them what to do. So this is a screenshot of our share folder, and there's a point of care folder, UMNC, and there are the clinics outside of the hospital, and their worksheets where they enter the quality control results. So this was what prompted to this spreadsheet. It was these errors. As you can tell there were two results that were outside of range. And the user did not rerun it. So at that time, we collected this spreadsheet a monthly basis. So we didn't really realize until the end of the month that those results were out of range. Nothing to do at that point, just rerun duplicates, controls, calibration, maintenance, but we couldn't really change that. Patients' results were reported, and we got a citation for them. So this is what prompted that. So now we developed this spreadsheet, and we put all kinds of information needed. Unfortunately, my mouse doesn't really show in there. So here, the result was out of range, but the operator was, because the message popped up in there, told them, oh, you have to rerun it, and she did. So that was great, and that proved that the system worked. And this one, they missed to enter the lot number expiration day. It wasn't urgent. I just put a comment there, and it was fixed the next time. As you can see below, there's a pop-up message that it tells them results must be in the shaded area, repeat results outside of the shaded area. So when they're going to enter the result in that area, they realize, okay, this is wrong, I had to rerun it. And also other form, and this is for rapid strep. So we have also problems with the user entering symbols, like for positive, we have plus, for negative, minus. But sometimes the symbol is not clear, and that's not actually allowed. So we develop drop-up answers. Like it will be positive, negative, and fail, and there's no way that they can miss that. And also over there's a pop-up message that says, stop patient testing. If the result fails in that range, they had to stop patient immediately and report that issue to the point of care coordinators. And this is actual, there's a spreadsheet that were used in the containment unit. And this based on the same concept, and that allows us to monitor that more efficiently, even though we're not using those on a daily basis, but we still go in there and report the results and keep documentations available at all time. So lessons that we learned. We learned that through all this process that coordination and collaboration between entities, departments, is the key to success. Physicians, adult ICUs, PITS ICU, NICU OB, nursing, lab, environmental services, supply chain, facility, security, infection prevention, education, ethics, MDH, and MS. All of these components are important to develop this lab and to maintain it. plan of care development, PPE planning, patient care and delivery and workflows, visitor guidelines, simulations and training. All of these were achieved during this process, and we maintain those and kind of review every time to make sure that we haven't missed anything. Partnership with other agencies, MDH, MAH, CDC, NIOS. The containment is our focus effort, just to maintain everything within that unit. Importance of the laboratory presence in planning. As you saw in the pictures, the laboratory is a main component of this because we provide testing, patient care right there in the unit, so nothing has to be sent or delayed because it's sent to the lab. And we prevent also any contamination in the other areas. Organizational impact, variation in staff engagement, complexity, and adaptability. All of those things that we work and probably had to review every so often. So all of the efforts, we were surprisingly rewarded that the federal government named our UMNC as a regional treatment for centers for Ebola and other infectious disease. So now it's our responsibility to keep up this unit. It's not only going to be Ebola. Next time it will be MERS, SARS, you name it. So we think that we are ready for any of this because the protocols are, if you follow the way they are, we should be prepared. So this is the way we work, and it was a very, very time consuming, but it was very satisfying that knowing that we did our best, put our efforts, our talent together, and I'm grateful that I'm part of this great team. Any question?
How many patients did you treat or did you have during the course of the unit being
We have one, but we have others that were ruled out when they were transported here, and they do the screening, and they were ruled out. So, but we have one for sure.
How do you virally inactivate something?
Good question. So IDDL came to us and trained us that how to kind of like give us a refreshing how to do the gram stain. And so we have a block heater. We apply the sample in there and let it warm up. If it's 30 minutes, we did it longer. We did an hour. And then we proceed to do the staining. Yes.
You also have to do 60 minutes in methanol, and then you heat it. So.
Great. That's true. Thank you, Sherry.
60 minutes in methanol after it's dry?
Yeah. No, methanol first, and then dry.
Yeah.
It's so we're just fixing it in the methanol, and then letting it sit, and then letting that dry, and then putting it on the heat block to inactivate it. Because they're just looking at the malaria. This is for malaria and for the gram stain slide. So the virus was inactivated at that time.
What happens if you get more than one patient? Can you only handle one patient?
That's a good question. Yes. At this point, we just have one room set for that. And we have the potential to increase the others, and maybe we will. But at this point, just one. And I think we probably would triage the patient to any other hospital that is, have a containment unit. Mm-hmm.
Are there any other hospitals right now that have people?
Yes, there are several. And United Hospital, Unity, and what are the others?
Children's.
Yes, children. Yeah. Mm-hmm.
I think Rochester, Mayo had.
Mayo?
On
Okay.
demand, they were going to set it up, but they were designated as a
Oh,
spot.
Mayo too? Okay. Any other questions? Well, thank you very much, and we will continue with our programs, and I think we have another visit with the vendors, and then we will have lunch.